So my title of my talk is MRI versus X-ray, and this may sound like a competition between two boxing champions, but I can tell you probably one has advantages, and I will elaborate on that. So this is my title slide, my disclosures you can see right here, and I will start off with a statement by the OARSI clinical trial recommendations regarding knee imaging in clinical trials. And as a summary of that very important paper that was published in 2015, it was stated that the goals of imaging the knee in clinical trials can include subject selection, monitoring disease progression and treatment effect, and/or identifying complications of the disease or the treatment. And I will simplify that a little bit, also known as eligibility, meaning imaging is needed at the time of screening patients as an outcome measure and surrogate endpoint, and for safety monitoring. And in my talk, within the next 8 minutes or so, I will focus a little bit on eligibility, touch upon briefly on the second and the third points. So coming to eligibility. So commonly today, patients are included based on radiographic severity and, of course, clinical parameters. And I'm just showing you here very briefly again to remind everyone of the Kellgren-Lawrence scale, which is still commonly used as an inclusion criterion. On the left-hand side, Kellgren-Lawrence 0 meaning no radiographic osteoarthritis, and Kellgren-Lawrence 4 meaning bone-to-bone contact, meaning end-stage disease. And also the Kellgren-Lawrence scale still defines radiographic osteoarthritis. Here, the cutoff between Kellgren-Lawrence 1 and 2, meaning everything that you see on the right is radiographic OA. And when we're talking about clinical trials, it is usually those knees that have established osteoarthritis but are not end stage yet that are included into clinical trials. And that these are those that you see in this yellow box. Okay, and you may think, all right, we have a clearly defined patient population regarding structure, but I'm not sure, this is not advancing now, of early to moderate disease, but I'm not sure that is the case. And for example, in the MOST study that also covers MRI readings of a large amount of patients, and we looked at those Kellgren-Lawrence 2 and 3 knees, we found that in these Kellgren-Lawrence 2 knees, 20% have no cartilage damage at all in the medial tibiofemoral joint, and more than 40% no damage in the lateral tibiofemoral joint. And when we look at the other side of the spectrum, a quarter of those supposed to have early osteoarthritis, Kellgren-Lawrence 2, show severe widespread full thickness damage all the way to the bone. And these are not just focal defects, this is really extensive cartilage loss. So Kellgren-Lawrence 2 and 3 is not a homogeneous sample of early to moderate OA, but a very heterogeneous. Now, despite the structural severity that needs to be defined at baseline, of course, we do not want to include patients that have disease ongoing that may not be amenable by a DMOAD or actually cause complications. This is a baseline image of a knee showing a little bit of medial joint space narrowing. And when we look at the 6-month follow-up, you can see that there's rapid progressive osteoarthritis with almost bone-to-bone contact at 6 months already. And where the arrows point here, you can see a fracture line. And if we had a more sensitive imaging modality at baseline, we can clearly see that that process was ongoing at the time of inclusion, and it is something that we call a subchondral insufficiency fracture that may lead to rapid progression and joint collapse. And there are other findings that are not visualized by X-ray that you may not want to include at baseline. These may include meniscal root tears, bone marrow infiltration, and so on. And these findings are not modifiable by a DMOAD. Now, moving on to a second point that has briefly been touched upon before regarding clinical parameters, and I will talk a little bit about enrichment strategies using imaging. And I will refer here to a citation by Dr. Fleming, who will talk later in this session. And he stated in a paper a few years back that regarding enrichment, there's considerable interest in identifying the subset of the patient population for whom an intervention would have a clinically meaningfully favorable benefit to risk profile due to greater benefits of fewer adverse outcomes. And again, I'm thinking about this very heterogeneous sample of Kellgren-Lawrence 2 and 3. So enrichment by MRI, for example, may be used to consider the mode of action of a given product or compound. And I will briefly touch upon also phenotyping that was mentioned by Tuhina Niyogi earlier. When we were thinking about clinical phenotyping, we may also consider structural phenotyping. And then finally, using a more pragmatic approach and looking at subjects at risk defined by structure and clinical parameters. So enrichment by MRI. So we're thinking about the mode of action of a of a given compound. And here you see an example from a clinical trial, short-term follow-up at 6 and 12 months, and you can see a focal defect here at the medial tibia, and you can see that there are some treatment effects by imaging. There's a little bit of cartilage growing here at the medial tibia. Okay, and this is fair enough. So an anabolic compound needs cartilage damage, so cartilage can grow. But on the other hand, if there's no cartilage damage, you will not see any treatment effect. If there's nothing to treat, how can you observe anabolic effects? And I mentioned before, in the most study, we had about 20%. If the FNIH cohort was even more than that, almost 30% did not have any medial tibiofemoral joint cartilage damage, which is the compartment of interest. On the other hand, when we are looking at the mode of action of an anti-catabolic compound trying to preserve cartilage over time and decrease cartilage loss over time, that compound likely will work best when there is something to preserve. And when you have widespread damage, full thickness loss, like in this image, that may not necessarily be the case. Now, moving on to phenotypes, just one single image example here. I said there are different structural phenotypes that can be defined, usually based, for example, on the degree of inflammation. So OA is per se not an inflammatory disease, but it has flares and it has episodes where it shows large inflammation, or subchondral bone may be involved. And given, again, the mode of action of that compound, you may want to consider enriching your sample by that. Just one slide, because I know Dr. Hochberg is talking later about the Spriferman trial. You all know that in the Spriferman trial, a structural benefit could be shown dose dependent in regard to cartilage thickness improvement. But again, you can find no difference when it comes to the comparison to placebo. You can see all of the dosage arms improved, but not better than placebo. But when looking at an enriched sample, of course, this is post hoc now, which is called the subjects at risk, which are those that have a certain threshold of pain and a certain minimal joint space width, you can see that structure modification translated into symptomatic benefit. But again, of course, this is a retrospective analysis, so to be interpreted with caution. So now just very briefly talking about structural endpoints or surrogate outcome measures when it comes X-ray versus the MRI. And this is an example, and you may again think, okay, this is rapid progression, maybe over 12 or 24 months, very clearly to be seen here, rapid cartilage loss. But in reality, these X-rays were taken at screening, and just the X-ray beam was changed very, very discrete by 1 degree, and you can see marked impact on joint space narrowing or joint space width, which is supposed to be a surrogate endpoint for cartilage loss. And of course, it's not only the position and technical errors that may lead to confusion. Of course, X-ray only shows you bone, and the joint space is an indirect measure of 2 joint tissues, which is the meniscus and which is cartilage. And meniscal extrusion, as you can see here on the right-hand side on the bottom row, is markedly responsible for joint space loss in this case. So it's non-specific, and probably some of you have seen these slides before. This is a follow-up image over 2 years. You can see no change in the medial compartment. There's an osteophyte here. But when it comes to the MRI, you can clearly see that there's cartilage loss posteriorly, of course, not covered by the X-ray, which is not shown on the AP or PA projection. So OA is not a disease of the bone. It's a disease of multiple tissues. We learned that over the last 1.5 decades. Many soft tissues are involved in the disease process. And given which tissue your compound is targeting, I think you should use your outcome measures. And now coming to MRI assessment, there are many different ways of looking at these images, of acquiring these images. And I would say the upper part here is more established methods, quantitative, semi-quantitative, and dynamic contrast enhanced MRI. The lower ones will be covered probably by Shamila in the following talk. And given again which tissue is your target tissue, you probably would choose one or another MRI method to assess effects of a certain drug on that joint tissue, if it be cartilage, inflammatory tissues like synovium, or the subchondral bone. Just one slide regarding safety, and this is partly already covered in my introduction when we were talking about eligibility. Many structural safety findings that may be considered an adverse event during a trial are not seen on the X-ray. A tumor here on the left-hand side, not common, but also not very rare, is called PVNS, or giant cell tumor of the tendon sheath. In the middle, you see osteonecrosis, which puts the joint at risk for articular surface collapse. And you can see here a delamination at the posterior of the lateral femur, or bone marrow infiltration here, as in the case of leukemia. And with that, I come to my final slide, summarizing X-ray versus MRI. So I still think that X-ray is needed for baseline disease characterization. We have to define structural disease severity by X-ray, otherwise it becomes very complicated. X-ray is non-sensitive to change, and it's non-specific in regard to tissue damage. It is challenging to acquire in a reproducible fashion in clinical trials, particularly when it comes to longitudinal assessment. It does not show findings that may be affecting efficacy at baseline or considered safety concerns. And MRI, in my opinion, is ready for screening purposes. I haven't talked in detail about that, but advanced imaging techniques, advanced image assessment leads to relatively straightforward results. It helps in enrichment, and these strategies we may want to consider them in the future. And all MRI methods are more or less complementary, and the choice is depending really on the mode of action, target tissue, and the length of trial. And with that, I'm finished with my rapid 10 minutes and looking forward to the remaining discussion. Thank you very much.